Cred că putem să începem. Avem sonor
Da,
online.
da.
Da. Sonorul online este de acolo. În engleză.
Good morning. We have a great pleasure to have a third international session within our Congress, and at the same time, as a preamble to the first Romanian-Italian conference, which will be held in October this year in Belgrade. Now we have the Romanian-Italian International Session. And I have the great honor to introduce my fellow and I dare say friend, Professor Luigi Tesio, who will co-chair with myself this session. And you will see, we have remarkable invited speakers from abroad. That is Professor Francesca Gimigliano, the president of the ISPRM, and some other fellows from both Italy and Romania. So let's start. The first work, Professor Tesio, will deliver the work entitled Specificity of Research and Outcomes in Physical and Rehabilitation Medicine. Please proceed, Professor.
Just a minute. See this. I have to. Probably I should see this one. So we can hear you.
Thank you, Professor. Thank you, Dr. Montano, for inviting me to this outstanding meeting. May I also thank the Director General of Istituto Oxologico, Dr. Mario Colombo, and our solid Romanian partner and the President Rehabilitation Center in Oradea, Felix, Engineer Jan Kodila. So thank you very much for supporting me in this event. Well, I will talk about quite a general topic, which is the identity of physical and rehabilitation medicine. And one should object that it is quite a useless topic, you know. But as you can see from the literature on the topic, what rehabilitation is and what rehabilitation is not is still a controversial issue. For instance, the Cochrane collaboration is striving to define rehabilitation papers from the point of view of their specificity. Whenever they try to realize a meta-analysis or a list of randomized clinical trials in rehabilitation, they find difficulties in defining when is an article a rehabilitation article. And so the problem is far from trivial. My personal idea is that these efforts are at risk for failing because rehabilitation is not enough to define our disease. Maybe physical and rehabilitation medicine is easier to define compared to rehabilitation and that thing, but we must reason on that. Look at the international definitions of physical and rehabilitation medicine. The ISPRM, the International Society of Physical and Rehabilitation Medicine, speaks of optimizing functioning, health-related quality of life, minimizing disability, and so on. The American Association of Academic Psychiatrists speaks of functioning of the whole patient as compared with a focus on organ systems and so on. Well, there are many other specialties that could say the same. So the problem is that we must reason on what PRM is and what PRM is not. What stands the P of critical for? What stands the R of rehabilitation for? I will propose you my idea. This is not the dominant idea across the nation society. So please consider that it is my personal opinion. Well, physical stands, in my opinion, from the nature, the outer world. The Greek origin relates to the nature in general. And so physical resources are those consisting in a transfer of energy or information from outside the body to or from the person as a whole. And rehabilitation, where is the app? Rehabilitation is a goal, but let's concentrate on physical first. So physical therapists in practice provide energy or information. So speech therapy is a physical therapy in this sense. From the outer world to the person. Physical diagnostics pick up energy or information from the person to the outer world. And rehabilitation actually is a goal of the person as a whole, means improving the person's interaction with the outer world, not an organ function, but interaction of the person with the outer world. If you accept this framework, then you will agree that physical and rehabilitation medicine lies at the intersection between physical resources and rehabilitation goals. Some years ago, I published this game. It was very difficult because it's like a quiz, you know? So the journal was quite disconcerted in seeing this kind of article. You can read the article and try to see which is the score you can get. The higher the score, the stronger your identity as a physiologist. Anyhow, the game is very simple. Imagine on the abscissa a gradient of how much rehabilitative is the goal. Goal is improving the interaction between the person and the world. On the ordinate, you see how much physical is the mean, is the resource you are using. Physical means from outside on the patient as a whole. Well, we give you some examples, but you find more in the quiz I published in this article. Some are diagnostic examples and some are therapeutic examples. See, for instance, shock waves for union fractures. They are physical, but they are not aiming at improving the interaction of the person with the world. Of course, indirectly, they do that, but they're not their main and primary goal. The same holds for ultrasound, ecography of the liver, for instance. And so they are physical means, but without an explicit rehabilitation goal. There are also non-physical and non-rehabilitative procedures, for instance, the anticoagulants or genetic testing. They do not aim explicitly at rehabilitation, and they are not acting from outside the person, but from inside the organs. There are rehabilitation procedures which are not physical in essence. For instance, botulinum toxin injection or bicycle stress electrocardiogram. The ECG is picking up signals from the heart, not from the person. So my idea is that rehabilitation stands here in this upper right quadrant. For instance, speech therapy and gait analysis, hand grip force testing, water exercise. As you can see, there are physical means applied to a rehabilitation goal. This is not to say that we cannot practice the other procedures in the other quadrant. Of course, we are positioned, but the problem is one of identity. And then be even more limiting. Specificity of what? We are looking for specificity of a medical specialty, not specificity of a social discipline, not specificity of an alternative or complementary medicine. So we must reflect on what does it mean for medicine in general being scientific. In one slide, can we summarize 5 centuries of Western culture, you know? The paradigm of contemporary science is defined as deterministic and reductionist. Reductionist means you look at the parts to understand the whole. You open a corpse and then you see what is there inside, and then you discover the laws relating the parts. For instance, heart and lung, or kidney and heart, and so on. So this is very similar to what's happening in physical science, in chemistry and physics. But you know, the person as a whole is not in this picture. So our roots are biomedical, we are physicians, you know, but our main outcomes are behavioral. Our outcomes are behaviors or perceptions of the whole person. So can we link behavior to biology? Otherwise, we shall be a sort of social assistant, social worker, but not really a physical medicine doctor. Well, we must reflect on this concept. Does PRM have organ specificity behind the person? Because when I show this slide, people attack me and say, oh, you are limiting the wide scope of rehabilitation. We are holistic. We are not organ bound. Well, this is a mistake because this pushes us outside the dominant biomedical model and we want to remain inside. Well, let's reason on that. This is my model. Our man is the left one. The physiatric homunculus have great upper and lower limbs, a great mouth, great ears, great nose and eyes. Namely, we are interested in the organs that the evolution dedicated to relationships with the outer world. On the right side, you see the man of internal medicine, a man interested in metabolic survival, metabolic balance, for instance, blood pressure, glycemia, electrolyte balance, and so on, temperature, body weight, and so on. So internal medicine now is dominating. You see a big belly, a big thorax, and very, very teeny limbs, you know. So we are interested in those organs, the nervous system, either peripheral or central, the musculoskeletal system, and the sensory organs. But again, be even more limiting. From which perspective are we dealing with these organs? Well, from the perspective of their relational impact. For instance, take the muscle. We're not specifically interested in muscle genetics, but we're interested in muscle physiology because it is through muscle physiology that you can climb upstairs, for instance, or speech, and or speak, and or move your eyes. So this seems a limiting model, but actually it's a versatile model because it gives strong identity to psychiatrists. And so relational organs from the perspective of their impact on the person's behavior. If you accept this, then you can accept also this kind of splitting between biomedicine, the dominant model, in which you study parts of the person. Things are easier from a conceptual point of view. You know, what happened is a series of replicable events. If you take an ECG, you have hundreds of potentials which are replicable. And events are passive, deterministic. You can predict that if you inject more insulin, then you will have a lower glycemic level. And you can apply physical laws to biological conditions. So we are exploiting all of the culture developed by physics and chemistry during the latest 400 or 500 years. But if you look at the person as a whole, then the person is unique. It's very difficult to think of a patient that really equal to another one, whereas you can think of cells which are equal to each other, or molecules that are equal to one another. It has initiative and values, and so it's quite unpredictable in his or her behavior, and she is subject to changes of social cultural norms. For instance, what is the ideal body weight is changing along the center. So it's a very difficult object to manage according to the dominant biological paradigms. So let me show you my metaphor, the ball metaphor. If you see the abscissa, you see a gradient going from parts of the person, cells, bones, organs, tissues, whatever you like, but parts of the person, individuals, clinical medicine. One physician treats one patient at a time, and population. Population, in this case, of human beings. So you have biomedicine, clinical medicine, and psychiatry is the best example, and public health. On the ordinate, you see how much science is attributed to these three areas. And you will see that, of course, the queen or the king, as you prefer, of the scientific model is biology, is not clinical medicine. Population medicine also has its relevance, mostly because of the economic implication. But, you know, clinical medicine now, it is at the bottom of the book. To substantiate with numbers what I'm proposing to you a look at the impact factor of the leading journals in the areas of cell biology, rehabilitation, and public environmental health. On the left side, you see the top journals at the moment. You see Nature, Rabies, Molecular and Cell Biology with an astonishing impact factor of about 110, 115. The top journal in rehabilitation at the moment is Journal of Physiotherapy with an impact factor of about 5. And then you see an impact factor of about 70 for Lancet Public Health. So the bowl is not fully invented, you know. The interesting point is the gradient along the abscissa. If you look at the median values of the journal in the three areas, the bowl is still there. You see the area of cell biology dominates, then the area of public occupational health is the second one, and then at the bottom you see rehabilitation. So let's think about that. So why we are the Cinderella of the biomedical model? Well, my solution is quite simple. We must revitalize 4 areas of research. The variables to be observed, the measures for these variables, the trial designs, and statistics. Let me have a fast glance on these 4 points. So the variables of the person are the so-called latent traits. They are variables that you can ascribe only to a person as a whole, not to body parts. For instance, independence in daily life. There is no body part that is independent, you know, you are independent. The same for pain, balance, quality of life, manual ability, fatigue, communication skills, continence, all of the psychiatric variables, all of the cognitive variables, they are properties you can only ascribe to a person as a whole, but they are quite unpredictable. So you cannot split the body and capture, say, manual ability and put it under a microscope. They are called latent traits, and there are reasons for that. And the second point is measuring. If you measure latent traits, there are problems. You know, if you measure a body part, you can use meters, kilograms, volts, microseconds, whatever you like. But if you measure behavior, then you can only have discontinuous observation, like in a school exam. Either you pass or not. So you must check a series of behaviors and hope that the more yes you check, the more of the variable is inside the person. So counts are not really measured. You know, if you buy 4 oranges, you don't know exactly their weight. And when you pay for the oranges, you pay for weight, not for number. So this is a very complex issue, which arose about 140 years ago in psychophysics first and in psychometrics afterwards. And it's still an open issue, but we must work on that. The question of limitations are very many and very well known. Non-linearity, 4 minus 2 is not equal to 6 minus 4, because 2, 4, and 6 are just labels you are assigning to these observations. Multidimensionality, you can add apple and oranges. And so the total number is a number of mixed objects. No? Floor ceiling effects. Your questionnaire goes from 0 to 100, but why not from 10 to 25? Missing values, how to estimate them? The cross-cultural equivalence. For instance, eating alone reveals more manual ability in Japan than in Romania or in Italy, because they use chopsticks. So being able to eat alone means being more able in general with mobility in different cultural contexts and so on. Lastly, another example is the one of nonlinearity. Take the Bartlett score, 0 to 100, for instance, but why 100 and not 120? And so people are bound to 0 and 100, and when they approach the limits, they tend to look the same. So you have this S-shaped function, which is far from a linear, from a proportional function, you know? So you need models that linearize this relationship. And the best option we have at the moment is the so-called Rush analysis, which is skyrocketing in the literature, but still needs full exploitation in rehabilitation. So the transformation of raw scores of questionnaires into true linear measures. Well, let's go ahead and look at the trial designs. The trial designs are not statistics, actually. They are the logic procedures allowing you to draw causal inference. You know, a patient can change after a treatment, but this may happen by chance. So, for instance, you apply double blinding, randomization, and so on to obtain a causal inference. But the trial designs must be specific for behavioral sciences. We cannot apply the classic randomized double-blind methods used in biomedicine. Consider that biomedicine works on diseases. For instance, you apply a research program to define if a drug for hypertension works better than another one, for instance. Well, you work on through single interventions. Either you take that pill or not. On single outcome, on populations, you are operator independent. You can apply blindness, randomization, match controls, equipoise, which means the same probability to respond to the treatment in treatment and control group, and so on. But if you work on individuals with disability, you have multiple interventions, multiple outcomes on single individuals, operator dependent. You can apply very often only open designs, unrandomized. You don't have unmatched control. So are we desperate? No. It's very simple. Don't reinvent the wheel, because in the so-called social soft sciences, these issues have been faced very, very well. We have plenty of knowledge from social sciences, which means education, marketing, psychology, and we don't need to reinvent the wheel. There are a lot of trial designs that can be applied to this kind of issues. But the problem is that we are attached to our biological paradigms. So we are not studying drugs. We are studying behavioral intervention. So we must change our mind. And statistics. So this is a huge topic, but I only face two issues, namely, we use decision trees usually, not a given drug and that's it. And we use different treatments and we change the cocktail depending on the progress of the patient. So we must validate decision trees, not single intervention. So does ultrasound works better than aspirin? This is the wrong question, because we decide to apply ultrasound to a given patient in a given moment of his recovery. Probably we associate anti-inflammatory drugs and so on. So we must use personalized treatments, but according to standard rules. Again, don't reinvent the wheel. If you enter a first aid department, the procedure that assigns you a white, yellow, red code are a decision tree. So you assign a different treatment to each patient, but depending on interactions between measures and decision. And you validate the whole tree, not the individual procedure. Again, this is missing in the rehabilitation literature. And so, last example. So the question usually is how much did the mean change, for instance, between treatment and control group or in a given group before and after treatment. And we test the significance of the change on the mean. But what about the single patient? Because I'm treating one patient, I'm not treating the mean of the patient. So the true question when I'm validating a decision tree is how many individuals did change? and who did and why. This is what we are doing in our everyday life as a physician. So don't reinvent the wheel. Don't be stick only to the abstract means, but consider also tangible individuals. There is statistics for doing this. Don't reinvent the wheel. This is an example. Suppose you have a questionnaire on the left side, 0, back in the game. The Gaussian distribution of the outcome is in the left curve, flipped vertically. And after a treatment, you see the right curve. Suppose the mean did not change significantly, maybe because of a small sample size, who knows? But if you look at individual patients in the so-called spaghetti graph in the middle, you see that the red patients did worsen significantly and that the blue patients improved significantly. You have significance tests for this. And so you can generate hypotheses, why those patients improved and why those patients worsened and so on. Otherwise, you are blurring with the statistics on the means that the treatment is really effective, but not on everyone and for different reasons. So don't reinvent the wheel. We have science even outside biology, So the take-home messages are only 3, very simple. The first one is a summary of what I just said, namely, physical and rehabilitation medicine roots are biomedical, but fruits are behavioral. Specificity lies at the intersection between physical means and rehabilitation goals, and specific scientific paradigms can and must be pursued in physical and rehabilitation medicine. The second take-home message is, we are not alone. There are many other, not so many actually, but some other relational clinical medical specialties, psychiatry, balnear therapy, sports medicine, occupational medicine, they all deal with the person as a whole. So I really think that we must share our effort to advance in methodological issues that can be applied very well to all of these areas of medical science. And the last one is, be careful. We are not an alternative complementary medicine because we are full compliant with contemporary experimental paradigms. We are not bound to biological paradigms, but we exploit them whenever it is necessary. And we consider hard and soft sciences as equally scientific. If we accept this, this model, then we can wear proudly this elegant t-shirt. Thank you.
Thank you very much, Professor Tesio, for this very elevated and at the same time very challenging presentation. No matter, unfortunately, we are the last session before lunch. Even if, unfortunately, we shall depass a little bit the time, I think is worth to have question and answers in the end of this session. Yes, now I'm have the great honor to announce the second speaker, Professor Francesca Gibiliano, the president of the ISPRM, will present us the work, The Disability Epidemics, the Need for Medical Rehabilitation, a World Perspective from ISPRM.
Thank you very much again for inviting me to this conference. And thank you to Professor Tesio for organizing this session. Sorry, started with the wrong slide. Okay. So I really like the title that Professor Tesio proposed for my presentation because the main aim of my message here is to underline how somehow disability has become epidemic all over the world. And this is very well explained in this publication that I already presented to you on my other lecture on Sunday. that was published in December 2020 that raised the point that there is a great need for rehabilitation. This is actually the first study to produce a global estimate of the need for rehabilitation services. And the results of the study are coming from the analysis of the data from the Global Burden of Disease Study 2019. This publication underlines that there are 2.4 billion people, that is 1 in 3 people, that could benefit from rehabilitation at least once in the course of their illness or injury. The general aim of the publication was to estimate the need for rehabilitation, presenting the prevalence data, but also the years of life lived with disability of 25 causes, impairments, and sequelae that would be amenable to rehabilitation at some point in the course of disease, using the data from the Global Burden of Study 2019. So it were extracted data on incidence, prevalence, mortality, years of life lost, years lived with disability, and disability adjusted life years. But above all, I mean, we were interested in the prevalence and years lived with disability data. So in the Global Burden of Disease Study, there were data on 369 diseases and injuries, plus almost 3,500 sequelae for both sexes, coming from 204 countries. And the data on this disease were divided into levels. So there is the broadest level that are of causes of death and disability, that is the distinction between communicable, non-communicable diseases and injuries. Then there were other broader, another level that were the 20 general causes of disease. Then at the third level, 174 causes that were specified even better at level 4 as 301 causes. And the previous Global Burden of Disease study was done in 1990. And from that one, 12 new causes were added to the framework. What are the years of life lived with disability and why we are so interested in this? This is a measure of the burden of non-fatal disease and injury related to the prevalence of each sequela multiplied for the disability weight. And the disability weight can range from 0, that is perfect health, to 1, that is death, and represent somehow the severity of the disease. So disability weights are defined, measured, and given in all non-fatal health conditions. And they derive from population surveys using a pairwise comparison method between random pairs of health states. How were the 25 health conditions for which it was calculated the rehabilitation needs selected? First of all, it were identified the 20 health conditions with the highest number of associated years lived with disability. Then it were excluded those health conditions for which rehabilitation was not considered an essential intervention, or it was indicated as a secondary intervention. Then there was a consultation between a group of experts within the WHO in the rehabilitation field. And so this is how the 25 conditions that are listed here were selected. There were 6 health conditions for the musculoskeletal disorders, 9 health conditions for the neurological disorders, 2 for sensory impairments, 2 for mental disorders, 1 for respiratory diseases, and 2 for cardiovascular diseases. And then there were taken into consideration cancers in general. Another important issue that was raised at the level of the publication of the global burden of disease was the estimation of comorbidity, because the way the authors found to solve this issue was to assume a multiplicative model for coexisting health condition. So, for example, the probability that a person, the proportion of person in the population with disease A, B, and C was related to the sequelae coming for all known these fatal health conditions that were not mutually exclusive. In 1990, we were used to reading this data, and we were actually quite struck by them, because at the time it was said that over 1 billion people globally experienced disability. That was 1 in 7 people. Now we are even in a worse situation, because the global key findings is that there are approximately 1 in 3 people that could benefit from rehabilitation. We know that the health condition for which people most often require rehabilitation is low back pain. We know that the numbers of years lived with disability had an increase of almost 70% between 1990 and 2019. And as for the European region, this epidemic is probably even worse, because there are approximately 2 in 5 people that could benefit from rehabilitation. And the most common health condition for which they could benefit rehabilitation were fractures. There was not a great increase between 1990 and 2019. This is probably due to the fact that data coming from Europe were already quite well defined in respect to the other regions of the world. If you look at this data, these are prevalence data for adjusted for age and sex. And this is a comparison between the prevalence in 1990 and the prevalence in 2019. As you can see, there is not much difference between men and women in this case. While if you look at the years lived with disability, in the new data from 2019, we can see that despite the same prevalence, the years lived with disability for women are higher than the ones from men. It's also interesting to see how musculoskeletal health conditions somehow are very important in the age groups between 15 and 64 and older than 65. We can see that in the first part of our life, there is not much difference between the prevalence of musculoskeletal health condition, mental disorders, and sensory impairments, for example, because they make like the 91% of all the prevalent cases. While going on with our life, the prevalent cases are mostly due to musculoskeletal disorder and sensory impairments. It's also interesting to see here the difference between, the prevalence of cases and the years lived with disability. And this is divided for regions. Unfortunately, the European region has the highest rate of prevalent cases of health conditions that we need for rehabilitation. But if you look, for example, here, we can see that the highest prevalence is for musculoskeletal condition. And this green here are the neurological, this orange here are the neurological disorders, sorry. And you can see that somehow the neurological disorders, as we expected, have are worse in terms of years lived with disability. While this is not the case for sensory impairments, whose pardon for disability is reduced compared to their prevalence. And here it is even more clear. I don't know if you can see well the different colors. Unfortunately, it's all in a scale of greens, because the first in the prevalence is for hearing losses, and that's the same for years lived with disability. Second, there is cerebrovascular disease, where there is an increase, and then there is low back pain, where there is no much difference between prevalence and years lived with disability. In this very nice picture, you can see that which is the prevalent case for requiring rehabilitation for each country. So let's say the black green is low back pain. In blue, we have fractures. Then the lighter green is rather injuries. And then this other green here is hearing loss. And this fuchsia is for vision loss. In Italy, the most prevalent cases for requiring rehabilitation are represented by low back pain, while, for example, in Romania, by fractures. So, which are the limitations of this study? The main limitation is that there are no primary data. So these are just estimates relying on predictive coverage and geographical proximity to countries with data, because they weren't able to get data from all countries. Also, there were included the diseases and sequelae that could benefit from rehabilitation at any point during disease or illness, which doesn't mean that all 2.45 billion people have acute need for rehabilitation. Another limitation is that for some diseases, the total prevalence was estimated by aggregating each of the sequelae, including moderate or severe motor impairment, rather than estimating disease prevalence on the basis of registries or prevalence studies. Another limitation is that the standardization and global comparison of disability weights can be a limitation if we consider the cultural, educational, environmental, and demographic differences across population, because these disability weights might change across the population, and it was our actually use an average estimation, and also there might be an overestimation of prevalence when there is in case of comorbidities, and also there was no evidence on the effectiveness of rehabilitation interventions for particular health conditions. There were low quality and there was a scarcity of study in this sense. I already told you about this very important moment for rehabilitation and for strengthening rehabilitation all over the world. That was the call for action from the WHO Rehabilitation 2030. We already stated the main areas of action and how it is important, for example, the collection of data using the ICF on the people that need rehabilitation and on disability in general, because this is a way to speak to our as decision maker, to make sure that these people are seen, because they have needs, and among these needs they need rehabilitation, to make sure that rehabilitation can be implemented in each country. Then there has been a second global rehabilitation meeting in 2019, and I'll go fast on this because we already studied about this. And it was clarified once again the need of education for health rehabilitation professionals and the need to increase the number of rehabilitation health professionals in low and middle income countries. This is true above all for PRN physicians. I mean, this is very true for PRN physicians, also for other health professionals, because we have practically no occupational therapists in most countries, or prosthetists and orthotists. The only rehabilitation health professionals that are quite in a large scale all over the world are the physical therapists. So we really need to advocate for education in physical and rehabilitation medicine. This is a summary of the WHO initiatives to strengthen and to bring forward the agenda of rehabilitation 2030. We spoke about this on Sunday, and also about how the ISPRM WHO liaison committee somehow collaborated in all these 4 initiatives. And we have as one of the speakers in this session, Professor Maria Gabriela Ceravolo, who actually contributed to rehabilitation competency framework. Just 1 minute to underline, as this COVID-19 situation has somehow showed how the population in need for rehabilitation is huge, because it was even growing during the pandemics and to the restraints due to the pandemics, and also to the sequelae coming from COVID-19. But unfortunately, and this is a slide that I adapted from a WHO slide, the rehabilitation was represented the most commonly disrupted services all over the world. This was for sure true in Italy. So the recommendation from the WHO was actually to find a way to continue delivering rehabilitation services, even in a situation like the one we have lived with COVID-19. My conclusion is that for sure rehabilitation is not a service for the few. That we are living in an historical moment for rehabilitation, and we need to advocate for rehabilitation. We need to work hard to make sure that the education for PRN physician is complete and can apply to all the needs for rehabilitation of people living with disability. And we need to advocate to make sure that rehabilitation is an integral part of the whole health system, and is especially in primary health care, to make sure that it can reach more people in need. And it's part of the universal health coverage. So the challenge is that we need to change how rehabilitation is viewed, not just as a specialized service, but a service for more people, because 1 in 3 people will need rehabilitation at some point in their life. I would recall you that on the September 13, there will be the pre-launch of the World Rehabilitation Alliance. ISPRM is applying to be a member of the World Rehabilitation Alliance. So you as ISPRM members will be, are part of the alliance. So it's worthwhile that we look at this initiative and we spread this initiative in our countries. And I'd like to invite you once again to come to ISPRM next Congress in Cartagena. The call for abstracts and proposal is are still open. Thank you for your attention.
Thank you very much.
Thank you very much for this enlightening talk on a world perspective on disability and rehabilitation. I will have some comments at the end of the session on this. So It's my pleasure to introduce now Dr. Monica Harras. She is the medical director of the Axiological President Med Center in Baia Felix, Oradea. And she will talk about the Romanian future of neurological rehabilitation, the need for new initiatives. Please, Monica.
Is it working? Hello, I'm sorry, I forgot my glasses on, so I have to get closer to this thing. Okay, so what is neurological rehabilitation? It is a long,
Monica,
complex.
scuze-mă, trebuie să vorbești în partea asta, este microfonul de online. Avem 200 de persoane care se uită la noi și rugăminte mare să vorbești cu fața spre ecran, astfel încât să captezi microfonul de aici.
Look at that thing.
Yes, please. Okay, it's okay.
I
They
say
like
this.
this.
And with this one.
And this one is here.
Okay.
Okay, thank you.
So, what is neurological rehabilitation? From my point of view, it is a complex process, often lifelong, of lifelong duration. It is a holistic process as it involves all aspects of human life, physical, cognitive, psychological, social, and even cultural. It is a multidisciplinary field of medicine because it can only be done with a very complex team. It is patient-focused and dynamic as it follows the evolution of the patient and his entourage, and interventions are tailored individually to match the needs to match the medical, social, and psychological changes in the life of the patient. But
It works. Yeah, it works.
Okay. The right one. No,
if I want to go back,
come back, please.
okay. So specific neurorehabilitation assessments and intervention has to target a multitude of aspects: the motor function, muscle strength, muscle tone, coordination, gait and balance, the need for orthotics and aid devices, the cognitive functions, the speech and deglutition, bladder and bowel control, physical pain, sensitive and sensory function, psychological and spiritual needs, social needs. And finally, we need to assess the needs for education and counseling and offer education and counsel to the patient. In view of all these endeavors, neurological rehabilitation has to take, the ideal neurological rehabilitation team is quite large. It's led by MPR specialists, which very often needs to consult with other specialists like a neurologist, a cardiologist. Also, part of the team needs to be a nurse, the nurse's aide, the physical therapist, the speech therapist, the occupational therapist, the orthotic specialist, a neuropsychologist, a psychologist, a nutritionist, a social worker, and of course, the patient and his family, caregivers, and friends. So, neurologic rehabilitation is a complex process, but it is a very dynamic field of medicine. In order to illustrate to you how fast neurological rehabilitation as a field is developing, I chose a marketing study on the market size for neurorehabilitation high-tech devices. And this very serious global market study showed that there is a potential for the growth of this market 2.23-fold in a decade. So a bit of statistics from Romania. With the aid of the National Center for Statistics and Information in Public Health, I retrieved data pertaining to the incidence of neurological diseases in Romania. The data was retrieved from family physician reports based on the 999 system codes. This system is specific to the Romanian physician network, I think. And we chose the most representative neurological diseases in adults, the demyelinating diseases, hemiplegia, paraplegia, and tetraplegia, other paralytic syndromes, cerebral infarction, unspecified strokes, and other cerebral cardiovascular disorders. And we estimated the annual incidence between 2017 and 2021 of the neurological cases in adults. As you can see, the general trend was ascending, with the exception of the year 2020, which might be the effect of the COVID pandemics. The global incidence of neurological disorders we found in Romania was 4.58 last year in 2021. So this incidence that we calculated is probably largely underestimated because of the non-presentation of the patients to the family physician, the exclusion from the statistics of rarely used codes, the COVID pandemics, which prevented the patients to present to their family physician, and probably some coding errors and some transmission of data errors. Because, for example, the incidence of stroke that we found in 2021 was estimated at 0.9 in 1,000, which is significantly lower than the global estimations that already exist. Now, I'm showing you the data from the Public Health Medical Management and Training School pertaining to the year 2020. They report the neurological cases. Bear in mind that a case does not mean one individual patient. It may mean re-hospitalization of the same patient. So the number of cases hospitalized in acute units were 175,000, while the cases hospitalized in non-acute units were around 35,000 cases. Non-acute units include neurorehabilitation, but they include a large group of Romanian specialties that are non-acute. So as you can see, the number of cases hospitalized in non-acute units is about 1/5 of the cases hospitalized in acute units. The mean hospitalization length is obviously longer in non-acute units, 40 days compared to 7.75. So when we look at the graphic, we see that chronic non-acute hospitalization accounted for only 17% of all neurological cases hospitalizations in Romania. Now, according to the National Center of Statistics and Information in Public Health, the total capacity of all units classified as adult neurological rehabilitation in 2020 was 1,068 beds, which would theoretically account for 389,820 hospitalization days in a year. Now I calculated the theoretical percent from, the graphic on the anterior slide, the theoretical percent of hospitalization in neurorehabilitation for all the neurological patients in Romania that were hospitalized in non-acute units. And the theoretical percent is around a quarter. So not so much. Then I looked at the length of hospitalization of neurological cases in neurorehabilitation in Romania. The data was provided by the National Institute of Statistics. And when we look at it, we see that myopathies, encephalitis, myelitis have the longest duration, 24 respectively, 22 days. The mean duration is 13 days, corresponding to the most frequent neurological diagnosis: hemiplegia, paraplegia, quadriplegia, other paralytic syndromes. And multiple sclerosis has an astonishingly short duration of hospitalization, 5 days or 3.5 days for related syndromes. Now I compare this mean duration of hospitalization in neurorehabilitation, 13 days, with other mean durations in other countries that I found published in scientific articles. All studies were done on a cohort larger than 1,000 patients. So in UK, they found only almost 71 days mean hospitalization for neurological patients in neurorehabilitation. Germany, 44.6 days in 2010. USA, 42 days for traumatic spinal cord injury this year. Canada, 79 days for traumatic spinal cord injury patients in 2017. China, 22.7 days for stroke patients in 2020. So compared to that, 13 days seemed a bit short. Now I took stroke as the typical example of pathology requiring neurorehabilitation because it is the second leading cause of disability and death worldwide, and because as the population is aging, the prevalence of stroke is increasing, and the health system will face increasing demand for treatment and rehabilitation of this particular pathology. Now, an audit of the stroke management in Europe, the Registry of Stroke Air Quality, an initiative of the European Stroke Organization, released a press release in Romania with the data from this year, from April to August, the pathway of post-stroke patients. As you can see, the great majority went home, 73.8%. Only 5.4% of the stroke patients went in neurological rehabilitation. 3.6% went in other hospitals. And in nursing home, 3.2%. The death rate was 14%. I compared this data with 7 years old data from the USA, a study that gave numbers about the post-stroke pathway in at the discharge from the acute unit. As you can see, also their patients go home. 81% of the patients went home, but the percentage of patients who went to a neurological rehabilitation unit was 7.1%, which is a little better 7 years ago. Now, the guidelines for the management of stroke issued in 2012 by the World Health Organization stated that Even with optimal stroke unit care, fewer than 1/3 of patients require fully from stroke. So, the World Health Organization recommended early rehabilitation in order to minimize impairments. Many studies confirm that an intensive, comprehensive rehabilitation program is essential to optimize post-stroke outcomes. So the question arises, why is it that so few patients are orientated towards rehabilitation after the acute episode? My conclusions: in Romania, like in most countries, there is a growing need and demand for neurological rehabilitation in the context of the increasing incidence and prevalence of disabling neurological condition, the accumulating evidence that rehabilitation is essential in reducing disability, thus diminishing the long-term social burden of neurological condition, and the increasing awareness of both the population and the medical professionals about the role of neurological rehabilitation. Romanian neurological rehabilitation is still hampered by some general factors. Like most European countries, Romania does not have intensive specialized rehabilitation home care services. Our home care services can provide mostly nursing and non-intensive physical therapy. Ambulatory rehabilitation is limited in Romania to 21 days per patient and per year in the public health system, while the private ambulatories are less economically accessible to the population. And this leads to the conclusion that the national inpatient capacity, who should compensate for that, is very undersized. What is still lacking in the neurorehabilitation field? Occupational therapists, which are skilled professionals, are still hard to find because this certification is newly introduced in Romania since 2011. And speech therapists specialize in degradation rehabilitation because in Romania, most speech therapists have a basic psychologist formation and therefore only work with speech and language disorders. The pluses of Romanian neurorehabilitation are a wealth of natural therapeutic factors like mineral waters, thermal waters, therapeutic lakes like this lake, peloids, mopetas, access to all types of pharmaceuticals used in rehabilitation, access to all, including the newest rehabilitation devices and technologies. And the Romanian specialists have a vast experience with a wide variety of electrotherapy procedures and have a vivid interest in all the new developments in the field of device-assisted rehabilitation. Also, the Romanian rehabilitation has great interest in information and experience exchange with specialists abroad and in implementing up-to-date rehabilitation protocols approved by international scientific societies. What's the need for new initiative? There is a very definite need for more adult neurorehabilitation hospitals in Romania, as the current capacity is insufficient. There is also a need to stimulate more professionals to train specific neurological rehabilitation skills, like the rehabilitation of deglutition and occupational therapy. And like all other countries, Romania has to keep up with the fast-paced emergence of new interventions and devices that require continuous education and training of the professionals. In this context of the need for new rehabilitation hospitals, I would like to say 2 words about the hospital where I work, which is a new rehabilitation hospital in Felix, our president, and has a large therapeutic facility offering a wide variety of rehabilitation treatments. We focus on intensive neurorehabilitation and implementing up-to-date protocols. And we work in close collaboration with Auxologico, which is an Italian non-profit foundation recognized as a scientific hospitalization and care institute since 1972. And this particular collaboration means we have access to top Italian specialist opinion. We are able to train our professionals using the auxological resources in rehabilitation of deglutition, for example, occupational therapy and non-invasive brain stimulation. Special thanks to the Institute for Statistics and Informatics for my statistics. Thank you. Thank you.
So thank you, Dr. Hara. It's my pleasure now to introduce Professor Maria Gabriella Ceravolo. He is Professor of Physical and Rehabilitation Medicine at the Università Politecnica delle Marche in Ancona, Italy. And she is the president of the Committee for Education of the Physical and Rehabilitation Medicine Board of the European Union of Medical Specialists. So, Maria Gabriella, thank you for participating.
Dear colleagues, dear chairman, I'm very grateful to the organizers of this Romanian-Italian session on physical and rehabilitation medicine, and very grateful to Professor Luigi Tesio for inviting me, for involving me in this very interesting event. I wish also to congratulate the speakers of the morning for their very interesting presentations. I will introduce and talk about the initiatives and activities of the European Board for Physical and Rehabilitation Medicine that I was honored to chair during 4 years in the past. These are my disclosures. And this is the outline of my talk. I will just introduce very shortly the scope and rules of the European training requirements by the UEMS, and then present the procedure, the pathway by which the ETR for PRM was developed, approved, and is currently under update. You will be the first in the world to hear about the update of the ETR that is going to be hopefully approved by the General Assembly on such a day, so within a couple of days, and then will be sent for approval to the UEMS. Then I will very shortly introduce something about the content of the recommended training requirements by the UEMS PRM board concerning postgraduate education in physical and rehabilitation medicine, and will focus on what we called the competency assessment through the entrustable professional activities. So very shortly, the scope of the European training requirement. In 1994, the UEMS adopted
Maria,
a
Maria Gabriella, you're not sharing the screen.
Ah, okay. But can you hear me?
We can hear you well.
Okay, okay. So, sorry. Yeah, okay. Now, can you see?
Yes.
Can you see my slide? Thank you. Okay. So don't worry about the previous slide. It was not important. In 1994, the UEMS adopted the Charter on Postgraduate Training. In 2005, the European Commission established this mechanism of mutual recognition of qualifications for medical doctors, adopting the Directive 2005/36 of the European Commission. And at the end of long procedure, in 2018, the UEMS section and board of physical and rehabilitation medicine developed and got the approval of the first edition of the European training requirements for postgraduate education in PRM. These are the rules, so it is a very long pathway articulated in 8 different phases, and this is the template by which the European training requirements have to be provided and decided specifically for any specialty. There are requirements for trainees concerning the specification of the content of training and learning outcome, the organization of training, included not only the curriculum, but mainly the assessment and evaluation of trainees. There are requirements for trainers and for training institutions. So the European PRM board detailed all these requirements in the first edition of the ETR, and you can see here that the process started in 2015 and then achieved the goal in April 27, 2018, when eventually the UEMS Council approved this document that you can find on the UEMS website as a PDF that is very easily downloadable. Currently, we are in train of updating the European training requirements, considering the fact that science is a never-ending process, and that the evidences on the efficacy of rehabilitation are constantly upgrading and updating, and they have to be taken into account when recommending the content of the core curriculum, but also the specificities of the professional role of a PRM physician. So the first phase after the approval of the ETR was the implementation of the same document through international and its diffusion through international scientific events. In January 2021, there was a very important event that was represented by the publication, the release of the Rehabilitation Competency Framework by the WHO Rehabilitation Program, together with the guide for using a contextualized competency framework to develop rehabilitation programs and curricula. And these documents were taken into account by the committee within the UEMS board that is updating the content of the core curriculum and the list of competencies associated with what is known as the specificity of our specialty. Last January this year, an extensive review was started to update the status of care delivery and the experience concerning training requirements across European countries. There was also an internal consultation within the section and board. In March, the first draft of the update of the ETR was approved by the General Assembly of the European delegates within the section and board. And in a couple of days, we are going to submit for approval to the delegates the final draft after having achieved the preliminary comments by peer reviewers, included the European Academy, the European Society for PRM, and an advisory board of PRM trainees. Hopefully in October, this draft will be sent to the UEMS committee for the assessment of DTR for review. So what are the main contents of the core curriculum? I mean the course learning outcomes, and then of the competencies that are expected a PRM trainee has to develop at the end of course. Here you can see the synthetic presentation of the 9 different chapters into which the core curriculum of knowledge and skills is divided. So the 9 chapters cover the very large body of knowledge that has to be accumulated by a PRM physician, and the skills that demonstrate that that knowledge can be implemented. So we have the fundamentals of PRM, including an in-depth knowledge of the International Classification of Functioning, any clinical knowledge applied concerning human anatomy, physiology, physics, biochemistry, and biomechanics, the instruments for clinical diagnosis and functional assessment, the very large range of interventions in PRM, the rehabilitation approaches to specific disabilities. So what is neurologic rehabilitation, musculoskeletal rehabilitation, oncologic, and so on. The approaches to disabling conditions in the 2 extreme phases of life, in the elderly and in children. And finally, 2 other important chapters covering needs for research in rehabilitation, as well as integrative and clinical rehabilitation sciences. And we have also given provisions on how the knowledge and the skill should be assessed as in order to understand whether or not the course learning outcomes have been achieved. These are the different levels to be used for assessing the level of knowledge achieved by the trainees, and the other 3 levels to consider to assess how clinical skills have been mastered by the trainees. But what is most important is that PRM physicians demonstrate to have developed competencies, because competencies and activities characterize the professional role of any physician, of any health professional working in rehabilitation, and not only in rehabilitation. So we referred to the rehabilitation competency framework, that is this important publication released by the WHO that distinguishes 5 very large domains into which competencies and activities of all those who work in rehabilitation can be grouped. So there is the domain of practice, that is the largest domain, where the PRM physician has to demonstrate to have developed competencies like placing the person and their family at the center of practice, establishing collaborative relationships with the person and their family, communicating effectively with the person, the family, the healthcare team, adopting a rigorous approach to problem solving and decision making, and working within the scope of practice and competence. And on the other side, we have the activities that are the real implementation of competencies in the routine practice, the tasks of obtaining informed consent, documenting information, conducting assessment, developing rehabilitation plans, and so on. And with the same perspective of distinguishing what are the competencies, that means the behaviors, and what are the activities that are that can be broken down in different tasks, we have also the competencies and activities relating related to professionalism, learning and development, management and leadership. That is a very important domain for the PRM physician who works as the leader of the rehabilitation team and research. And also for this characterization of the course training outcomes, the ETR provides the levels that can be used to assess to what extent any activity is performed, any competency is shown by the PRM trainee. Very shortly, I wish to introduce the concept of the entrustable professional activities, because it's the core of any postgraduate education. Here you can see a schematic process that from the rehabilitation competency framework accompanies us to the development of the curriculum goals. And we focused in the update of the PRM ETR on the part concerning the assessment, because we know that assessing what a PRM trainee has achieved as knowledge, skill, but most importantly as competency, must be assessed with taking in mind that at the end of the course, the trainee, the PRM physician of the future is ready for tomorrow's demands. So he or she can be trusted in his or her capability to deal with any new patient, unfamiliar challenges, new knowledge. So the assessment cannot be just based on the assessment of what the trainee knows or knows how or shows how, but mainly on what he can demonstrate to do in the real context of professional practice. So the attachment, a very important attachment to the updated European training requirement for PRM that is going to be approved very soon, is a list, is a framework that shows what are the different activities that can represent those scenarios to assess the competencies of a PRM trainee at the end of course. As you can see here, it is an Excel sheet where you find on the first column the domain of competency. Here you see the competency of practice. Then you will have for each row an activity, and for different columns the clinical setting where that activity is assessed. You can have the clinical rehabilitation unit, an acute care serving, outpatient care, specialized brain injury rehab, specialized spine injury rehab, and any other clinical setting where the trainees have completed their training. So here all the different activities that belong to practice, you can read them. They start with collecting information and go through preparing consultations, facing problems in urgent condition, and so on. For each one, like for instance, managing patients with spasticity, there is a full provision of all the prerequisites of knowledge. So what the trainee must know how, must show how, and eventually has to do in each clinical scenario. So if you wish to apply this Excel sheet to assess the competency of PRM trainees at the end of course, you can completely rely on a very, very detailed list of how to prepare the clinical assessment scenario, and also how to rate the competency, the behaviors, and the ability to complete the tasks by the trainees. I believe that my time has already elapsed. I wish just to thank you for your attention. I wish to ensure that this never-ending work on how to ensure the achievement of standards for good education, not only in the postgraduate, but also for the undergraduates, is going on. And for the undergraduates, I wish just to remind this paper that has been very recently published, that focuses attention on the fact that people with disabilities currently could be inadequately served by the healthcare system, and that one cause of this discrepancy is that medical students receive limited training in the care of people of disabilities. So in the context of our European training requirement for postgraduate education, there is also a component that is dedicated especially to the undergraduates. So to prepare the physician for the future to be competent in the management of people in need of rehabilitation. And again, thank you very much for your kind attention.
Excellent and stimulating talk. We'll have some comment at the end of the meeting. So it's my pleasure to introduce now Professor Onose, and it's not presentation, I guess, because the chairman of the Congress is a psychiatrist with a highly esteemed and a very high reputation at the international level, mostly in the field of spinal cord injury. So he will talk about topic challenges for PRM and balneal climatology in the context of a global alert, demographically aging population. So,
Thank you. Thank you very much, Professor. First of all, I want to say I'm deeply honored and delighted to be a part, a speaker of such a high level and distinguished top panel of speakers international. Then it is very pleasant for me to speak after a member of the board of the UMS, as our Congress has received 44 points of the continuous medical education, which is a huge figure and a record. Third, you may see the logo of our Congress is not on the first slide. It's not because I forgot, but to avoid redundancies, it will appear in a very honorable context for us on the last slide. Should I come closer because
Yes, please.
yes. So I should begin
Okay, it's okay that.
from here. Yes, well, let's see. It's not so evident.
Îndreptați spre lector.
No. Okay, so as this is a corollary endeavor, and we had over time different works on parts of the subject matter, I consider all the fellows I mentioned here as co-authors of this work. Yeah. Demographic works show that the average life expectancy in birth starting from 1980 it has by around 0.2 annually, and it seems like it will increase. Yet chronic disease priorities and disability, which characterize the pathology of the elderly, become more and more prevalent and older ages, of course, and a population which who lives more is not necessarily healthier, but on the contrary. This is sorry for a slide in Romanian, but because the picture. So I translate it. It's a problem that medicine has progressed very much, especially in the emergency one. So it can save lives in critical situations, but unfortunately has not the possibility to regenerate and so to avoid very severe disabilities. Just an example, a person that needs to be amputated a limb, we do not have any medicine or intervention to grow it back. And this goes also for the central nervous system, for which we do not effectively have any medicine or intervention to cure, really to cure the lesions. We can, by rehabilitation, to adjust and to compensate. So, as Professor Milan Dimitrievich, very important professor at the Baylor College in Texas, said, we accumulate, because life is saved in most critical situations, we accumulate veterans of the contemporary medicine. Chronic diseases represent a major burden of pathology in Europe. 86% of deaths come from chronic diseases. So it was a very great focus on the emergency medicine, but the pyramid of the pathology is quite converse. The chronic diseases, specifically diabetes mellitus, the cardiovascular illnesses, the cancer, the neurodegenerative sickness, including of mental type and musculoskeletal sufferers, are composing most of the chronic diseases, and they affect more than 80% of the person aged over 65 years. So more people aged over 65 mean the specific of pathology in elderly is the multimorbidity, and this leads in multi-disability. And this disease burden is multiplicative. So I give you two notices. By 2060, the population age of 65 and more will almost double. And the population age of 80 years or more almost triple. So you younger fellows, you live in a very gray world. The WHO has dedicated the first decade of this millennium to three targets: the elderly, the quality of life, and the musculoskeletal health. And it continued this over the last decade that ended 2 years after. We don't know yet which will be the this decade dedication. It was estimated to be regenerative. We shall see. So the musculoskeletal health impairs if it isn't well managed, even the healthy and active aging. And because nobody is Santa Claus, this is endorsed by the United Nations, WHO organization, the World Bank, and the Ministry of Health in 70 countries to try to diminish the consequences of the pathology musculoskeletal, and I should add also the neuromyoarthrokinetic pathology. And this is the World Bank and the World Health Organization World Report on Disability, focusing and giving to the rehabilitation an extremely great importance. And this is finished in October 2 years ago. The CRODIS, the cross-country collaboration and new added value in the field of non-communication diseases, supported by the European Commission. I'm telling all this because I'm rapporteur of the Standing Committee for European Doctors on both chronic condition management and healthy and active aging, because I have two specialties. I'm on both sides of the coin. My first specialty and love is the rehabilitation, but I have also the specialty of gerontology and geriatrics. So you may see here the joint statement of improving the employment of people with chronic diseases, because this is a very important social problem. Elderly should be kept in the field of activity, and for that they have to remain healthy. And this joint initiative asserts that strengthen chronic disease rehabilitation, recovery and employment, and rehabilitation are key supporting patients in managing their conditions, including in terms of working life. And in particular, it should be considered that it's cost effective and not cost sparing, because implementing rehabilitation program should be seen as an investment in health rather than an expense. And that should be free access to rehabilitation without discrimination for all these individuals. And as Professor Gimignano said, there is the Horizon Rehabilitation 2030, a call for action. 46 countries and 200 specialists are involved in this very important project. And we shall, every medical record should also focus on functioning. And this is in connection with the World Health Organization, ICFDH, you know very well, the new, let's say new from 2001 paradigm regarding human functioning. We shall speak about this immediately. And we have also the WHO Global Disability Action Plan 2014-2021, better health for all people. Unfortunately, the pandemic came upon us, and there are not yet very clear statistics of the outcomes from this very important strategic orientation of sanitary politics at international level. And about speaking about the human functioning, you know very well the ICF-DH paradigm, which made that combating the disabilities is a crucial goal for health. And Professor Gimignano also showed this very well known schemata, the domains of body function, activities and participation, and of course the contextual factors, especially the environmental one, and the personal are very diverse. So everybody knew that we speak about the elderly, the third age. Well, Lasset, an important author, practically describes 4 ages in the life cycle. The first is the era of dependence, socialization, immaturity, and education by 16 to 18 years till entering the labor market. Then an age of the independence, maturity, responsibility, and accumulation, 16, 18 to 59, 64 years, that is the labor activity. And then an eon of person achievement completion by 64 to 75, 80 years. And the 4th age is the one of final dependence, decrepitude, and death over 75, 80 years and over. And there is not a very strict limit, because another vision is that a person in the 3rd age, called young adults, attain normal age of retirement, and specifically they have a good autonomy, whereas they can be under the age of 65, but to have a poor health condition. But the oldest all are over 80 years, and it is not the same. They can be still independent, but the rule, the statistic rule is that they have lost their functional independence and autonomy and need health and social care. Well, if they do not have an economic standing very good. Therefore, a marker suitable to objectively monitor rising health across life cycle of the individuals, especially in terms of self-autonomy, but also productivity that is working life, is a healthy life year. Professor Gimignano spoke about it. And this measures the lifespan spent in good health or disability-free life expectancy, and differentiated the years free of any limitation to and this measures also indirectly the quality of life. And quite it's a core set indicator, and it is incorporated in the Lisbon strategy to be reported by all the countries in the European Union. And quite the opposite, but rather complementary, is the disability adjust life years, DALI, synthetic health state indicator that combines year of life lost due to premature mortality and years of life lost due to time lived in state of less than full health. Senescence is a natural disease, as said Aristotle. Practically, we have here from birth to all the life cycle 2 kinds of reactions from our body: adaptative and deteriorative. Classically, the studies of gerontology spoke mostly about the deteriorative, but rehabilitation helps us, including to improve the adaptative component. Practically, aging has a biological determinant and a psychosocial one, and the biological determinant has two dimensions: the genetic one and the metabolic of depreciation one, of the wear and tear, because we cannot pass through life without making the inevitable losses of morphological structures involved in our survival. And this deteriorative modification may be amplified in different organs in multiplicative effect, according to the general theory of systems, Bertalanffy and other colleagues, but also the adaptative ones can work at the same time, so making multiplicative effect in the favorable way of preventive and counteracting the deteriorative path. The two determinisms practically lead in a balance which, as we age, it is in favor of decrepitude to decline the balance, the sustentation, the balance of homeostatic. This goes lower, and the capacity of adaptation to stress is lower in the elderly. Senescence is a differential and variable process, as practically of all of us and each of us. So the two components, intra-individual and variability, is differentially is intra-individual, and variability is inter-individual, and it fits very well with the genetic dimension. So this is a gradual deterioration. There is no 0 point, or practically 0 point is the birth, and this is decrease in average of the performances, whereas we cannot speak in a normal aging of the failure of any organ. And so the same goes for the accumulation of pathology, which is, as I said, the characteristic of the elderly, the multi-morbidity. There is a, not humoristic, but however, interesting statistic that says that people over between 65 and 75 years have, in average, 4.6 disease. Of course, they are complex, they are chronic, the person is autonomous, but any of them can be aggravated. So senescence in itself is not a disease, but lowering below the optimal function level of the majority of biopsychological processes, but by measure. So this process do not occur equally in all the structures. This is the differentiality, and of course different in different people. And eventually, the practically overall, the daily use stress, which is necessary for our survival and anti-entropic behavior, turns into distress, which is characterized by the incapacity of adaptation. We know very well in Romanian there is an expression, bătrânețe haine grele. That means oldness, heavy clothes to be wear. Aging can thereby be understood in lowering biological capabilities and progressive alteration of integration control mechanisms at all the levels: subcellular, cellular, tissue, metabolic, humoral, of organ apparatus system, as well as in relation with the inner and external background of this level. At molecular subcellular, practically the key point is the growth of the number of alterations of the information flow that comes from the DNA through the RNA messenger in the cytoplasm to the ribosome for the residence of the protein. This can be impaired by ionizing radiation, ultraviolet toxin from the ambient cellular metabolic product. And here we have that we eat too much. The oxidative stress, especially the caloric stress by fast food products, which bring many blind calories but not nutritive elements, will excessively work in so intensively soliciting the digestive and metabolic functions. Practically stress is contributing to aging by three mechanisms, non-mutually. Disturbing the immune function, the oxidative stress that leads eventually including to extended apoptosis, but also to inflammation, fibrosis, atherosclerotic, extensive aberrant neuronal apoptosis, and the lower telomerase activity. That means that the stress of aging leads to shortening of the telomere, and this in some will lead to more death, cellular death, and in some to aging of the body. Within the reactive to stress the link between the brain and the immune system, there are the well-known by Besedowski and colleagues in the mid-80s, the immunoneuroendocrine reaction that involves the neuroendocrine system as a whole. And so that makes the psychosomatic link, mind-body connection, manifested in both eustress and distress. So stress, I have systematized it as being in duality between physiological and pathological. And there are 7 such processes which I have ordered alphabetically. Aging, that is a normal paraphysiological, nobody escaped from aging, but also major risk for polypathology. Apoptosis, necessary for instance, to develop the birth for the embryon, but also when they are extended up pathological. Hyperthermia, that is reactional. We do not combine fever at below 37.5, but it can be also pathological, for instance, birth or installation. Hypothermia, except the bear hibernate and survive, but also pathological by process, for instance. Inflammation, reactive, but also pathological autoimmune disease. Neuroplasticity, the learning, but also pathological reorganization. Pain, nociceptive, they alarm us about the imminence of a lesion, but also there can be neuropathic pain. And eventually stress, which is stress, a vital stimulus. We cannot live without stress. But when it departs our capacity of adaptation, it becomes pathogenic distress. And in young people and adults, the stress can be also, if it is very strong, to leading to death, but usually it induces maintenance by a hormesis type of response. Although in elderly, it usually depass the capacity of adaptation and is possibly to lead to death. So in recapitulative synthesis, regarding aging modification, all over the body, aging structural system become disorganized and defeated the anti-entropic biofunctional profile. More fat is deposited, active tissues hidden or lost, individual cells increase in size but decrease in number, almost to 1/3, and connective tissue between cells, muscle fibers, and bones increases and becomes less. Look how many objectives for rehabilitation. And this is very 63 years, 78 years, and 93 years. You see the support basis between feet and the posturing. And there are here some biological parameters. Some of them we do not modify significantly, and others that modify. And also sarcopenia, which is a geriatric pathology, but very interferent with us in rehabilitation. And practically, we can do right nutrition and therapeutic exercise intervention. So you see the interference with that. This is a very study from this year. Very interesting that practical hypertension is connected with sarcopenia, and the drugs that combat hypertension, that is the blockers of angiotensin and the blockers of the receptor angiotensin, have some effect on diminishing sarcopenia. Distress is a concept of paramount importance and negatively related to quality of life, wellness, and not only, and also with the working capacity. And stress and depression are to be recognized as major causes of sickness and related to working capacity. By 2060, 30%, more than 30% of the workers will be over 65, and overall the work population will shrink. This is a great problem of interference, medical and social. Aging practically becomes more evident after 40, 45 years, and it is characterized by vision deterioration of day. And look up below this line is all targets for rehabilitation: psychometric reaction time, intellectual abilities, motor and fine abilities, coordination, loss of muscle cells, half of muscle it's at 75 years compared to 30 years, and of course the duration of joint. Here there is a statistic, European Eurostat. The age mean by European countries, the lifespan in Romania, practically it is 7.8 years less in men than women. The mean this problem is the 5.2 in European, and practically there is also a connection. People with more education live more, and this difference is very big in Romania. 10 years less live the persons with less education, whereas females, the difference only 4 years comparable to the European one. Consequently, the European Commission have launched the European Innovation Partnership of Healthy Aging, having an overarching target to increase European citizens the number of healthy life years average with 2 years by 2020. We don't know if they have reached it yet. Well, and physical rehabilitation is based on evaluation, which is necessary to see the entry level of the patient to make a functional prognosis for recovery, to set rehabilitation realistic goals, to evaluate the patient status over time, and to guide therapy, content, and delivery. And we have this specific objective, the D mnemotechnically taken from the rheumatologist: distress, disadvantages, dysfunction, disharmony, dependence, dissatisfaction, dollar cost. Of course, that is not an objective. In neurorehabilitation, we have also, and I have adapted mnemotechnically, this anesthesia, dysphagia, dyspraxia, this control of bladder and bowels, dysphagia, dysphoria, dysreflexia, dystonia, respective spasticity. And additionally, because I couldn't make them by D, we have also the deconditioning of physical effort, endurance, muscle, cardiovascular, pulmonary, or intellectual neurasthenic. And of course, deconditioning in breathing, ventilation, dysfunction, but also inflammation and ischemia and dorsal. And in elderly, we have the 15E, the geriatric problems: immobility, instability, incontinence, intellectual impairment, impairment of regional hearing. They said that the 4 are most important. I couldn't say that if you don't see or don't hear is not so invalidating at the same time. Insomnia, asthenia, impecunity, you see the shift to social and economic. And of course, the infection and last but not least, iatrogenesis. So the targets of the European Union: prevention, care, cure, and active aging, and the triple win for Europe: the sustainability of the social systems, the quality of life of elderly, and the support of the economic through the expertise and the work of the elderly that are kept to be kept in activity. And this will make the silver economy turning into gold. Health value of geriatric tourism. This is from the document of the European Union: increasing healthy life years, creating friendly environments, increasing the retirement age, creating the European market for health-related products, innovating new citizen transition by literacy, their literacy enhancement, and with using the whole digitalization, the new health domain. The main type of stress regarding the work capacity is a stress for people that become old that make physical effort, for those who make intellectual effort, and the retirement stress. And this requires an important involvement between the collaboration between PRM doctors and gerontogeriatricians and occupational medicine specialists. So we add to the related medical specialties with the rehabilitation also geriatrics and occupational medicine health. So we have here integrative combined. So here we come to the concept of the Romanian specialty for physical and rehabilitation medicine and balneology, because we merge here physical methods traditionally known, for instance, hydrotherapy and thermal treatment, with a modern rehabilitation concept. And here I want just a second. You see, Professor Giustini, you know very well, in a work set that the functional recuperation, this was the term, in the years of 50s, it has been adopted recovery and rehabilitation, but initially was recuperation because we in Romanian are supporting the term of recuperation. And we have here the unitary specialty in Romania, whereas in France or Germany, this is split into physical rehabilitation in urban areas and balneology in spa, thermalis, for instance. So here we have a unitary specialty. The links between them is the hydrotherapy, which can be made also by natural mineral water, but also by artificial sources. The photobiology, because we have natural heliotherapy, I don't divide because we have to say here in science, and also artificially, and in halotherapy, natural aerosols were but also made by artificial sources. So this is a great importance of the anti-stress, relaxation, prophylactic fitness, mise en forme, and including anti-aging courses in the balneary spa procedure that merging also with the health tourism, but which has to be very professional promoted. So we have here, this is when I was running the National Institute of Gerontology and Geriatrics. Look, we have some important medical results that make geriatric. And here are some pictures in the Institute of Gerontology and Geriatrics because the physiatric procedures are very, very strong represented there. And this is the tribute. This is another word which I'll discuss maybe later. To Professor Anibal Teohari, the founder of Scientific Romanian Balneology. We celebrate this year and next year 100 years of our specialty and society. And the Professor Ana Aslan, member of the Romanian Academy, founder not only of the Romanian Gerontology and Geriatrics, but one of its promoters at the international level. And here you see the last slide that our Congress is on the official website of the ISPRM, and we warmly invite you to the first Romanian-Italian Conference of Physical and Rehabilitation Medicine in October in May. And thank you very much for your attention.
So maybe we have time for some short questions on the floor or even from the online audience.
From online. It's only possible to speak to Professor Francesca Gimignano and Professor Maria Ceravo. Only them if they can chance.
So Professor Ceravo and Professor Gimignano are still online.
Yeah.
Oh, well, I have a comment on Professor Gimignano's talk. We are sure now that during the COVID pandemic, rehabilitation was not perceived as a priority. And this was certified by the WHO across most countries. Rehabilitation was a service that received the greatest cuts. And the same happened in Italy. We had a lot of patients with neurological consequences of the COVID infection, for instance, Guillain-Barré syndrome, strokes, encephalitis, and so on, that were sent to infectious diseases unit with no care for the disability consequences. So I think that there must be a reason for that. So why physical and rehabilitation medicine is not perceived as a priority? We cannot only invoke the fact that politicians are bad guys. There must be some deep reason. So my idea is that is not perceived enough as a specialty, a scientific specialty, and so this contrasts somehow with the idea that if it is perceived as a specialized service, that then it is not for the many, but it is for the few. And so what's your opinion, Francesca, on that? Because this is a sort of contradiction, you know? The less you consider rehabilitation as a specialty, the less it is considered by the general healthcare politics. But the more it is considered as a specialized service, the less it is considered as a service that must reach potentially everybody. So what do you think about this apparent contradiction?
So one of the reasons I think that rehabilitation services were disrupted somehow during the pandemics is that they are not considered as a life-saving intervention. That's the main reason. And there is, I think that it's difficult to make people understand how a sequelae of a disease can be actually so disabling and also so costful for the society as it is, because we know that a person who has an important neurological health condition, but also musculoskeletal condition, we saw fractures are one of the most common health conditions for requiring rehabilitation. And we saw, for example, after the pandemics, many people who had a hip fracture went under surgery, but did not went under rehabilitation, and they cannot walk any longer, even if, with a hip total hip replacement. I mean, we know that usually these people should walk after the first day or during also the first day. So I think that the main reason it's that it's not seen as a life-saving intervention, and just we don't care about the futures enough to care about rehabilitation. As for the issue of specialization, on a side, I mean, you're right, because I think, in my opinion, rehabilitation should be at all levels of care, because it should be implemented in primary health care. And this is essential because otherwise we cannot strengthen rehabilitation in low and middle income countries. But on the other side is a specialized intervention, as in the neurological field. So I don't think that this is a contradiction. I just think that probably we can make some distinctions in the level of services, but rehabilitation is needed in different rehabilitation services. And what we should try as PRM physicians, as physiatrists, is to strengthen the idea to other medical specialists that, I mean, it's important to have the point of view of a rehabilitation physician, and not just to have a physical therapist doing the job, because it's really not, I mean, the result, it's really not the same. And we know it, but other people doesn't. And we need probably to make also health economic study that shows that when a service is somehow run also by a PRM specialist, it makes a difference to the quality of the service given to the patients, and it can be also save some costs. I don't know if it was clear enough.
Thank you. Any other comments on that? That's quite enlightening, Professor Giuliano's answer. So I have a small question for Professor Ciravolo. So please inform us as soon as it is official, the new listing of capacities and activities. Very, very much interested. What about the policy of the training centers across Europe? No, because I think they are very little compared to the relevance that they have. At the moment in Italy, we have 3 of them only. I don't know if there are Romanian training centers. So can you tell us how can we implement this idea of certifying rehabilitation centers as training centers? Because this is a good stimulus for the centers themselves to improve their clinical skills. So what about the policy for increasing the number of training centers across Europe?
Well, this is a very difficult question because you know very well that this activity on the part of the board to foster the standardization of PRM postgraduate education started more than 30 years ago, around 30 years ago. And the advantages are not felt so strongly by everyone in Europe. So there were several countries, especially those countries where the specialty was established very long ago, that did not acknowledge the need for certifying their training centers because they considered that the education they delivered was already more than a standard. So we are within the European PRM board using so incentives to make training center understand that the certification can be a seal of excellence and can represent so a stimulus, a source of pride for the quality of care that is delivered, not only the quality of education, but also the quality of care that is delivered within the center. But unless we have the support by the ministries of health and so by the governors, it will be always a very demanding activity, the one that aims to diffuse the culture of European certification, of demonstrating that the education is meeting all the standards that are considered so at the European level. I'm not sure that I can satisfy your curiosity about this very sensitive issue. It's the same with the certification of fellows. We have the same difficulty in those countries where the number of people, where the number of PRM physicians is very high, but they do not have any problem in finding an occupation. So the role, the value of European certification is not acknowledged at all. So to my opinion, there should be a combined effort on the part of the UEMS bodies, but also on the part of the governments. Otherwise, we can't have that European standards are recognized as important, because there is so the feeling that so the national requirements are enough. Maybe you have some suggestion, Professor Tesio.
No, I have not. I'm very proud that we are one of the three units in Italy. It was a demanding test, achieving that certification. So there's a contradiction because, you know, on one side, the European Union supports the Unione Européenne des Médecins Spécialistes, the European Union of medical specialists, but on the other side does not encourage governments to achieve that certification, because, you know, we have a common currency, the euro, but we don't have a common currency of education at the moment. So it's really strange. So I think that both the governments, but also the scientific society should push towards this international certification, and also both of fellows and of training centers. So this is a recommendation also for the Romanian society. We are doing our best in Italy with the Italian scientific society, but for sure, we must do more in this field, because you did really an excellent job. So it's very absurd that across Europe we have different conception of what is a specialist in physical and rehabilitation medicine. So thank you so much.
Thank you.
I want also to thank very much the speakers and of course special thanks to Professor Tejo, my fellow co-chairman in this session, and especially very big thank you to Professor Gimigliano. She is for the second year on our side. She participated also for the work last Congress last year. And we look forward to meet her in person in Maile Felix in October, as she confirmed. So thank you very much.
Thank you to you. Bye. Have a good Congress. Bye.
Bye. Thank all of you. Enjoy the Congress.
Thank you. Enjoy the Congress from Professor Charlotte. So, Professor Ronosa, we can close the section. So thank you for all. Thank you for all the participants, and thank you for the
Online were
invitation.
about 200.
Oh, yes, that's for sure. Thank you to the more than 200 people attending online this conference. Thank you so much. Thank you.